So a 20-year-old male presented to the ER with complaints of chest pain and fever. And amongst other investigations that were done, the CT chest showed a fluid-filled cavity, which was communicating with the large right-sided hydropneumothorax. This was the radiologist described this as a ruptured hydrated cyst with cystopleural fistula. Along with this, there were also multiple infiltrates in the right lower lobe, along with effusion. At this point, I think we have summed up what is the organism that we'll be talking about through the course of this presentation. Following the imaging, a chest tube was inserted and purulent fluid was drained. This was sent for some microbiology investigations. The pleural fluid was sent for the culture in Gram-stain, and along with this, serum was sent for Echinococcus IgG antibodies. A blood culture was also sent. At this point, the patient was shifted to the ward. He was started empirically on albendazole, on vancomycin, and piptaz, and was planned for thoracotomy plus decortication. This pleural fluid was received in the microbiology lab. It was greenish yellow fluid, and upon Gram stain, it showed numerous pus cells along with echinococcal scolices with hooklets and some rare gram-negative rods. The serum that was sent for the echinococcal IgG antibodies also turned out to be positive. This is a picture of the hooklets that was seen in the Gram stain. Having seen these hooklets, we did not forget about the gram-negative rods, so we can set up the usual culture paste that we do that include chocolate, sheep blood agar, a trypay that we have that contains McConkey, MSA, and SDA all in one plate. We also set up an anaerobic SBA and a cooked meat broth to enrich whatever organisms might be hiding. And along with this, the primary team was obviously informed that we had seen echinococcal hooklets, that the IgG was also positive, and we were also seeing some gram-negative rods. So the patient at this point was empirically well covered with albendazole, piptaz, and vancomycin. The next day, we observed growth of two types of gram-negative rods. Both were non-lactose fermenters. One were non-lactose fermenters that were oxidase positive. The other were oxidase negative. The cooked meat also turned to be turbid. The Gram stain was done, which showed gram-negative rods. This was further subcultured onto the sheep blood agar. Patient was at this point afebrile and he was prepped for surgery. On day 2, the organisms finally yielded some identification and susceptibilities. The oxidase positive organisms were identified as Pseudomonas aeruginosa, which were pretty sensitive to aminoglycosides, ciprofloxacin, ceftazidime, piptaz, imipenem, and meropenem. The oxidase negative organisms were identified as Stenotrophomonas multifilia, and this was also sensitive to levofloxacin and cotrimoxazole, and was resistant to minocycline. On day 2, the patient had the surgery done, was received back in the ward, and based on the susceptibilities that we had reported for the gram-negative rods, levofloxacin was added to his regimen. Eventually, on day 8, the patient was discharged in stable condition on albendazole and levofloxacin. This is the culprit behind it. We pretty much know about this. This is Echinococcus granulosus. It's a cestode, and when we delve into the etymology of the word Echinococcus, echino means sea urchin or prickle-like, something with horns, and coccus means a spherical microorganism. So this is a worm which belongs to the phylum Platyhelminthes, the class cestodes, and it has been described for a long time, even since Hippocrates. It has been documented that certain cysts were documented in livers, and it was likely the same organism, Echinococcus, the hydrated cyst, that was being described in Hippocrates' era. And eventually, in 1901 was the first time that Echinococcus was officially labeled as the name was actually attached to this particular pathogen. This is the tapeworm. It is very famously known as and those of us who have pets, particularly dogs, would know about this because we regularly carry out deworming of our pets, of the dogs in particular, because dogs are known to be the definitive hosts for this worm. What do we mean by definitive host? A definitive host is a host in which the adult form of this particular pathogen thrives. And apart from dogs, some other canines like wolves are also known to be the definitive hosts of Echinococcus. And then there's another entity that is known as the intermediate host, which in this case is sheep and goats and some other cattle as well. An intermediate host is one in which the adult form is not present, but the larva form is present. Coccus, basically, in the broad sense, it consists of 9 species and genotypes. And the most common one is the G1, which is the one that is most prevalent, and it causes hydatid cyst. It causes particularly the hydatid cyst of the liver, lungs, and other tissues. And the hosts for that particular genotype is dogs as the definitive host and sheep as the intermediate host. But then there are other genotypes as well, G3, G6, G7, which are found in different kinds of hosts. For example, the buffalo strain, the sheep strain, and goat strain. So yes, there are different kinds of genotypes of Echinococcus as well. The life cycle is very important to understand the pathogenesis of Echinococcus. The adult form, in this case, the worm, which you see in the picture of which you're seeing on your screen, this is the adult form which is present in dogs. This is about 1 to 7 millimeters in length, and you won't find this you won't find this worm in the intermediate host or the dead end intermediate host such as humans. These will be found only in the definitive hosts, dogs and other canines. These worms, they have the sexual organs, both the sexual organs, the male and female parts, and they produce eggs which are shed into the feces. These eggs can then survive for a long period, up to several weeks in the environment. These eggs are then ingested by the intermediate hosts, such as the sheep or even humans. These eggs then hatch in the intestines, releasing the oncospheres, and these oncospheres then localize to different organs, most particularly the liver, because of the portal circulation. Liver is the first organ that it encounters. So that's why liver is the most common site for these oncospheres to lodge themselves and then create this hydatid cyst. These hydatid cysts, they remain in place, they enlarge, and if they get ruptured, then they release protoscolices, which then seed within the body, and these daughter cysts can then occupy some other organs as well. When it comes to sheep or other herbivores that harbor these larvae and these cysts, when they die, dogs eat their meat, their organs, and they consume the cysts or the scolices. Those scolices then when they enter the dog's system, they develop into the worm, the adult stage. This is a very good diagram that represents the life cycle. This is very common. I'm sure we've already all seen this. And just like we explained, the cycle is basically between the dogs and the sheep, and humans are just incidental dead end hosts. And there's a reason, because dogs are associated with particular livestock. They have a particular livestock role in which they tend to they act as a shepherd dog, and they move the herd and look after the sheep. So that's why dogs are supposed to be the most common definitive hosts, and the sheep are the intermediate hosts. So once inside the human, as we discussed, these eggs hatch into first the oncospheres, and these oncospheres localize into organs, and inside those organs, those oncospheres form a cyst. This is known as the hydatid cyst, and this is very particularly unilocular for Echinococcus granulosus. And it contains thousands of different individual scoliosis and daughter cysts. Usually the cyst remains of the organs. It can persist there for several years, even up to decades, and the patient remains asymptomatic. It keeps enlarging in size, and usually the infection is detected incidentally on imaging. It usually just causes some mass effects because of the enlarging size upon the organ. However, if the cyst ruptures, then problems arise, all sorts of problems. There's a severe allergic reaction to the cyst antigens, and patients might even go into anaphylactic shock. And moreover, the daughter cysts that are delocalized from the cyst, they seed into many other sites. However, thankfully, this scenario occurs in less than 10% of patients according to literature. This is a histopathologic uh, diagram in which this, a section of the cyst is described. If we start from the outermost layer, which is labeled A, this is the host tissue. B is the lamellar tissue, which laminated tissue, laminated layer, basically, not even the tissue because this is acellular. C is the germinal layer, which is nucleated. The round body, the oval to round bodies that you see inside this first D is the brood capsule, which is the daughter cyst, and inside this brood capsule, you can find some oval protoscolices. These what's labeled as E is the protoscolices. Proto means first, scolices means basically worm. So protoscolices is the stage before the actual worm. And F is labeled the hooklets, and it might not be clear in this slide, but let's see the next slide where hooklets will be much more defined. Over here also you can appreciate the hooklets. This is one particular protoscolix. And over here, the hooklets are pretty much evident. They have evaginated. And the germinal part of this, as we saw the image earlier on of the adult form, where the head forms a germinal body, and that germinal body gives rise to several glottids, proglottids. This has started to evaginate at this point, the protoscolix. The diagnosis of echinococcus centers around imaging. And in imaging, ultrasound, X-rays, CTs, MRIs, all are very helpful. All have different sensitivities and specificities for different organs. For instance, ultrasound is very good for detecting the hydatid cysts in the liver and in the abdomen. But when it comes to the chest, then X-ray performs better than ultrasound in certain literature. And the second mainstay of diagnosis is serology, in which we have several options, such as the ELISA, the Western blot, the indirect hemagglutination, the indirect immunofluorescence test, the IIFT, and some rapid immunochromatographic tests, which have newly been introduced. However, there's several problems with the serologic diagnosis. For instance, there's a lot of cross-reactivity with other cestodes, with other helminths, such as tinea and cysticercosis, and several other helminthic infections. And number two, there's the serologic tests. The performance of these serologic tests basically depends upon the underlying prevalence of the disease as well. That's another limitation. And for this and many other reasons, the CDC has recommended that the best available serologic diagnosis is obtained by using combinations of tests. For example, using enzyme immunoassay or IHA for screening, and then those positive reactions should be confirmed by an immunoblot assay. When it comes to the treatment, WHO has very appropriately designed a stage-wise approach for the treatment of echinococcus hydatid cysts. Depending on the stage of the cysts, how mature they are, how big they are, and how conveniently operable they are, different modalities have been suggested. For symptomatic complicated cysts, surgical resection in toto, which means total resection of the cyst, has been proposed. However, this is not very commonly used, and what's more commonly used is the pair therapy. This is particularly recommended for inoperable cysts, but even in case of symptomatic complicated cysts, it's been very commonly used. The pair therapy stands for number one, P for puncture, and this should be done very responsibly, very carefully. It should be done under CT guidance with a very fine needle. It's important to note that the cyst should not be aspirated blindly, and because if, as we've discussed before, if the cyst ruptures, then the daughter cysts seed throughout your body, and they localize into different organs and also cause anaphylactic shock. So it will be a very serious situation. So the puncture is a very sensitive stage. It should be always done under CT guidance. The second A is for aspirate, where you remove 30% of the cyst fluid, and I is for installation of an equal volume of viscoelacetyl agent, such as 95% ethanol, for 30 minutes. After these 30 minutes, all the cyst content is reaspirated. And many surgeons also use a cover of albendazole therapy for the procedure as well. For young cysts, and the cysts, when we talk about young cysts and inoperable cysts and complicated cysts, all of this has been defined radiologically. So the young cysts can also be just treated with anthelminthics alone. With albendazole is a preferred choice, 400 milligrams twice a day for 3 to 6 months. So in Pakistan, several studies have been done which have documented the prevalence, have explored the intermediate hosts and other parameters, other information about Echinococcus granulosus. One such study in 2020 revealed that the prevalence of Echinococcus in slaughtered animals was 2.77%, whereas 7% of the dogs were infected by Echinococcus granulosus. Unfortunately, we do not have a good surveillance system in Pakistan, and a systematic review that was done was published in 2020, documented that there were almost 1,700 cases that had been reported of Echinococcus in humans. Moreover, it also leads to a heavy financial burden and the economic burden, because according to a study, cystic Echinococcus in livestock causes economic losses of $2.76 per infected sheep or goat, and $1.65 per infected buffalo, cow, or camel. And we don't have data about the prevalence of Echinococcus in humans in Pakistan, but we can get some idea from our neighboring countries. For instance, in Iran, an average of 12,000 surgical cystic Echinococcus cases were reported per year. And the number of asymptomatic individuals was estimated to be around 635,000. So our situation might be comparable to Iran, and it's very common, very prevalent, not as rare as we expect it to be. So what went wrong with our patient? The cyst obviously got ruptured, but why did that happen? Was there any sort of trauma? Did the cyst become too big and it started impeding upon the blood vessels, which led to necrosis? Was it iatrogenic? Turns out that there was a history of thoracotomy of this patient that was done in Afghanistan, and obviously it was not done right. That led to the rupture of the cyst. And upon the rupture of the cyst, it caused the secondary infection with 2-gram negative rods. And this is a scenario which is not very uncommon, where the cyst gets ruptured and then it becomes super infected by some other bacteria or even fungus. In fact, in chest, in the cyst, hydatid cyst of the lung, Aspergillus species have been reported to also cause a super infection. And in Spain, a 2010 study was done in which 7.3% of the patients had a super infected cyst. So this is also not very rare to see a super infection of a ruptured cyst. Cystic Echinococcus can be prevented by simple, effective measures. For example, performing and implementing good human hygiene, deworming of the dogs, better slaughtering practices where the entrails of the slaughtered animals are not fed to the sheep, to the dogs, very rather optimistically, the WHO in 2021 claimed that a program combining vaccination of lambs, deworming of dogs, and culling of older sheep could lead to elimination of cystic echinococcus disease in humans in less than 10 years, considering it's been around since the time of Hippocrates. That seems rather optimistic, but well, we'll see how this goes. Rather difficult in our part of the world. So thank you so much, everyone. This was the presentation. The floor is open for discussion. Yes, Dr. Faisal.
Yeah, so thank you so much. This is a great overview. I have just one question in terms of diagnosis. Can you go back to the diagnosis slide? So what do we do here at AKUH and other places in the country?
Yep. So in AKU, we have an ELISA-based serologic technique in which antigens are coded in the wells, and then echinococcal antibodies bind to those antigens, are detected by a substrate enzyme, and we only report it as positive, negative, or indeterminate. We do not report titers of echinococcus IgG antibodies.
So and what you're saying is this is a sensitive, non-specific test because then you have to confirm.
Yes, exactly. The CDC recommends that this should be confirmed by an immunoblot assay. The particular commercial kit, it depends on the commercial kits as well. The one that we use claims that it has a greater than 95% sensitivity and greater than 95% specificity, and it depends on the different kinds of antigens that have been used in the different commercial assays. But the CDC recommends that it should be confirmed by an immunoblot assay at least.
And WHO?
The WHO, I'm not really sure about because I read this about the CDC only.
Okay, all right. But okay, this is very helpful because so that would mean that a negative test pretty much rules out echinococcus.
Pretty much, because the problem is with cross-reactivity. If it turns out positive, you're not sure if it's echinococcus, if it's some other helminthic infection, or if it's even if genuine at all because of the underlying prevalence. It's not validated as such. So that's the thing, that if it turns out negative, you do have a pretty good chance. It does have a good negative predictive value. That's what's been discussed in literature. But imaging is supposed to be the gold standard of diagnosis.
Okay, great. That is helpful. And then the other thing I just want to add is in the treatment. So what this is often sort of missed by our ultrasonographers also, that in treatment, remember WHO has a classification of the cysts. We're talking about liver cysts now, and you classify it as CE1, CE2, CE3A, and 3B, and then CE4. And the management depends on what the cyst age is, and then what the size is. So in some cases it's spare, some cases it's surgery, some cases it's nothing. You just wait and watch and see. So for the last couple of patients, I've asked the ultrasound people to please stage the cyst, and they were able to do it, but for some reason they don't do it automatically. So just for the fellows on who are listening, that this is an extra thing, you just don't forget to do it. There's another classification along with this, which I can't pronounce, Gibri or something with a G, and that also has, depending on the class, the treatment varies. I think that's class Skibitini chart classes.
Yes, exactly, Dr. Faisal. Thank you so much for the knowledge.
Dr. Kauser unmuted, but she's not saying anything.
Okay. No. I was just, as you was highlighting, Faisal, the appropriate surgical management of such patients is also very, very important, because this patient had been initial management was done in Afghanistan, and I think the drainage of the cyst was not done appropriately, and the closure was done too soon, and that is why it led to infection and development of empyema. So this patient had a very huge empyema when he presented to AKU. So the appropriate management of initial surgical intervention for such patients is also very, very important, apart from the parasitic therapy. Thank you.
Yes, and in some cases, especially in the cysts which are outside the liver, we may need to give lifelong albendazole. I have one patient who's in Oman who actually has neurocystocercosis, and it's in the neuro cysts, which are in the spine, base of the spine. And if he ever stops his medicine, he starts developing neurological symptoms, and he has to just continue. So I've just told him, yeah, literena, you can't stop it. And similarly, if there are multiple in the lung, you just have to just continue. There's nothing much more you can do except for just keep it at bay.
So for microbiology colleagues, it is extremely important that if it is mentioned cyst on any specimen such as liver or lung, it is very, very important that we actively look for scoliosis. And so, Ali, can you go back to your gram stain image? So, and you can pick it up on gram stain as well. So if you are like experienced in that, and if you look for it, you may be able to pick it up. So for even ID fellows, Ali, can you explain what is observed on this particular gram stain?
Sure. So what we are seeing is a protoscolix of the echinococcus along with the hooklets. The hooklets is what you see vertically emerging from the body. So this is an echinococcus protoscolix, which is showing hooklets. It's very pathognomic, very unique, unique structure that we see, which immediately prompts us to think that it is echinococcus. So it's a very hallmark pathognomic of echinococcus.
Ali, this is 1,000 times magnification, right?
Actually,
So yeah. Okay, this is gram stain. So this is not the protoscolix. This is the hooklet only, just the hooklet alone. Okay. Protoscolix mein na pura, it is at, you can see it at a lower magnification because it's a much bigger structure, exactly, right? And this here you only see the hooklet, and sometimes that is a whole problem because it has ruptured, it has released, and the scoliosis may not be seen. It's basically the broken or it's the fragmented pieces that you see in the gram stain. So you may see a hooklet, and that's what is visible right here.
Right. Thank you for the correction, Dr.
I hope everyone can see the sharp point and sort of like a Danish shoe. वो उनके clogs नहीं होते हैं. This is what it, or elf shoes. This is what it looks like a shoe. Ali, there's a question here. I think they're asking if the patient survived. Did you mention that?
Yes, I mentioned that the patient was discharged on day 8 and he was stable when he was discharged. He was discharged on albendazole. So yeah, the patient did survive and is probably doing much better.
Do we have any follow-ups later? I mean, after a few months or so?
I think so. I think it was in the discharge summary, but I haven't.
I might have gone back to France. Okay. Yeah, that was enjoyable. I actually quite liked it. It was a good refresher. Ethan came back.
It was. Thank you. Because somehow last month I saw a lot of echinococcus. I don't know.
Dr. Faisal, that is why I asked him to present. So there were many patients. This one and I think, है ना?
So I was like, outbreak हो रही है कोई. मगर उसके बाद पे कम हो गए. So I think it was just sort of not statistically significant.
Yeah, we get these feelings very frequently. It's like just the way listeria suddenly just comes in groups of 3. and then it just disappears.
Yeah. I mean, echinococcus really can't cause the incubation period is so long, and the time from infection to detection is probably so long that, but Listeria, I guess we could get outbreaks. Anyway, sorry, I'm musing. So I think we're done. Yeah.
Dr. Faisal, I have a question. Just curious, the cases which you received, the patients that you saw were from the same geographical location, village, or anything similar in Pakistan?
all over the place. All over the place.
Okay.
एक और क्वेश्चन है मेरा डॉक्टर फैसल, डॉक्टर वाजिद बात कर रहा हूँ. What are the chances for the development of the shock-like conditions after the rupture of the cyst? For example, this patient has presented with the ruptured cyst. No? So most of the children, when they have presented with the rupture, they usually are very sick in condition, landed in an emergency within a shock-like condition. So what is your experience in the adults with the ruptured cyst?
So I do remember looking this up. I don't know why, and I think Ali mentioned about 30% is what is known in literature, or 10%.
Yeah, so one of our books, the Mendel documents this figure as less than 10%.
But I was just wondering, I mean, you don't see them very often. Just, I mean, because Wajid seems to have seen them. With kids, it seems to happen a little bit more frequently.
Even during the surgical, people are very reluctant to do very pair surgery or with drainage because they, if there is any chance of the rupture, they will go into the shock. So surgical people are very reluctant to deal these patients with any surgical procedure in pediatric population.
So I think, Wajid, they do it after a course of albendazole. This is also a strategy, I think, which they use.
So interestingly, the albendazole pre and post surgery is recommended for liver cysts, but they recommend not to use albendazole for lung cysts when they're doing surgery. I don't know why. I don't know why. I have to look this up, but maybe some of the other ID physicians would know why there's a difference. I know it's there, but I never really looked into why.
Interesting. I was wondering.
Okay. Next, किसकी बारी? किसी को कुछ पता है? Next week.
I think we should एक दफा ना हम हर उस पे डिस्प्ले कर दिया करें कि नेक्स्ट किसका है. Okay, let me check.
Who has a Sunil? Do you know? Or is that Sunil? Who's Lukman? Who's Lukman today?
Zahir is responsible. Zahir
खुद ही नहीं आया सबको रिमाइंड करके. Oh, no, Zahir. ZU must be Zahir.
Yes.
ZU Zahir?
I think ZU is Dr. Zahir. Or Dr. Sunil can take over as well.
चल फिर देख लेते हैं. Just Zahir या Sunil या Asma या if you want one of us to do it. Let's just make sure that the schedule doesn't need to be revised with new fellows coming in, like new programs. सबकी बारी आनी चाहिए.
Yeah, मैं वही सोच रही थी कि well, new programs have been incorporated. Professor, I think that's what Zahir had done. He had, you know, Zahir and I think one other person. I think was it Niva? So there were two people who had made the rota. I'm not sure, from two different centers, and they had incorporated new programs as well. So that's why.
Okay.
I was wondering कि माइक्रो का सिर्फ एक ही प्रोग्राम है जो वो है, because I think इंडस में भी है और शौखाना में भी है. So I really hope कि वो लोग भी present कर रहे हो, because this is very useful. But I just feel खैर this is और एक और अब तो CPSP वाला भी होना शुरू हो गया है, so that's also good.
हाँ. CPS wala is so very good. Chale. Okay, I really have to go and round.
Yeah, we'll share kiska wo hai ek dafa dekh ke na dhoond.
Chale, Ali. And Ali, thank you so much. This was really, really nice. Thank you.
Thank you so much.
Thank you, Ali. This was a very nice presentation. Very good.
Thank you.
That is